Good morning, everyone. Welcome to the National Health Insurance Authority's monthly beneficiary educational session. Our theme for our topic for this morning's session is Let's Talk Obesity. On Monday, March 4th, the World Health Organization recognized World Obesity Day, and in their 2014 statistics, they ranked the Bahamas as the sixth most obese country in the world. This morning, we are privileged to have Dr. Ariane Davis Simmons and Dr. Jeanette Martin to speak to us on Let's Talk Obesity. Dr. Davis Simmons was born in Freeport, Grand Bahama, and she is part of a medical family with her older sisters practicing pediatric dentistry and pulmonary critical care, respectively. Upon completion of high school, Dr. Davis Simmons attended the University of Maryland and graduated in 2004 with a Bachelor of Sciences in Biology. She pursued her medical training at the University of the West Indies in Trinidad and completed her clinical training at the Nassau campus in 2010. Her interest in diabetes and endocrinology began early in her medical training, spurred by the diagnosis of diabetes in her father and type 1 diabetes in her 9-year-old niece. She initially watched them struggle in different ways with their diagnoses and management, and knew that if she understood this field, that she could make it easier for them and others to successfully maintain their health despite very real challenges. Her expertise includes and is not limited to diabetes management, diabetes technology, insulin pumps, and continuous glucose monitors, thyroid disorders, thyroid ultrasound and biopsy, medical obesity management, pituitary, parathyroid, and adrenal disorders. After completion of a rigorous fellowship program, Dr. Simmons was eager to return to the Bahamas to use her skills to serve the population, which inspired her to pursue a career in endocrinology. Dr. Jeanette Martin. Her professional education and training include a doctorate in advanced studies in human behavior, which has prepared her to teach, consult, and lead mental health, physical, and wellness programs across the lifespan. Jeanette's work experience in the health and wellness industry spans over 30 years, and she has worked as a registered nurse in the clinical field, the medical insurance industry, pharmaceutical sales, health and wellness consultant, and GEMI Health and Wellness. And presently, she is the Director of Wellness of Weight Loss and Diabetes Education at Doctors Hospital Health System. Over the years, comprehensive and holistic programming resulted in positive health outcome for employees and return investment for employers through reducing absenteeism and presenteeism. Jeanette also facilitated health and wellness programs throughout the Family Islands, the Caribbean, including Jamaica, Dominican Republic, Trinidad, and Barbados. This morning, we would like to welcome these two intelligent ladies who are going to educate us on obesity. And right after their presentations, we're also encouraging all of our viewers to please place your questions in the chat features in Zoom and on Facebook Live. And we will happily read the questions to Dr. Simmons and Dr. Martin. Good morning, and Dr. Martin, you're on.
Good morning, everyone. Thank you for having us. I don't know how to, you said press it this way? This one?
Right.
Nothing's moving.
It's okay.
Do I use this?
Yeah, use that.
Okay, so this morning, myself and Dr. Davis Simmons will engage your attention, get your attention on this topic that is so relevant now and timely in the Bahamas, throughout the world, in particular Bahamas. So this morning we'll talk a little bit about what obesity is, the prevalence worldwide and in the Bahamas. We're going to focus mainly on the Bahamas as well. Dr. Davis Simmons will come on and speak about the physiology of obesity, health risk and treatment for adults and youth. And then I will come back to you and share lifestyle behavior modification, focusing on nutrition, fitness, stress management, and mindfulness. We'll close with comments and then move on. So, what is obesity? Obesity is a medical condition described as excess body weight in the form of fat in our bodies. We have an accumulation of this fat that can lead to severe health impairments. And Dr. David Simmons will speak to those health impairments and the risk factors that excess body fat in our body causes. The prevalence of obesity across the world continues to rise. And in the world today, we have 2 billion adults who are currently living with overweight, and 650 million of them are obese. Now, what is obesity then? Anyone with a body mass index 30 or above. Normal body mass index ranges from 18.5 to 24.9. And overweight range from 24.9 to 29.9. Obesity starts with a BMI of 30. Now, not everyone who has a body mass index of 30 or above has excess fat, because we do have some persons who are weight trainers, they lift a lot of weight, resistance training, and so their muscle mass takes up the space of where fat tissue would normally result in a high body mass index. So you can be walking around with a body mass index, a weight trainer, or someone with a lot of muscle mass, and your fat percentage be within the normal healthy fat percentage for your age and height. And that is why it's important for us to not only look at your body mass index, but to look at the person when they come into us and really perform a body composition assessment and examination, including fat percentage, so that we're able to, determine whether it is all fat or fat and muscle. Okay, so the World Atlas 2022 published by the World Obesity Federation, predicts that 1 billion people globally, including 1 in 5 women and 1 in 7 men, will be living with obesity in 2030. Well, we're experiencing that not only throughout the world, but in the Bahamas. And so we're going to get to our Bahamian numbers. It is expected that 1 in 4 of us will be living with obesity by 2035. Childhood obesity also is on the rise, and since 2020 to 2035, it is predicted that we will have a 100% increase in childhood obesity. We're experiencing that and seeing that in the Bahamas now as we speak, and I will share those numbers with you. The greatest number of people living with obesity are in the low and middle income countries. We're experiencing that here in the Bahamas as well. So these are the Bahamas numbers. In the Bahamas, we have over 70% of adults who are either overweight or obese. In 2014, the Bahamas ranked 6th as the 6th most obese country in the world. And Bahamian women account for over 50% of the obese population in this country. So if you see, look at that graph, I have it broken out. We have 70% of adults who are either overweight or obese, and 45% are obese. And these are results from 2019 here in the Bahamas. So we're in 2024. Where do you think we fit now? We are over, definitely over 50%. Men account for 68% of either overweight or obese, and 30% of men were obese in 2019. We have seen the increase of obesity among men as well. And we see them not only coming into our offices at Doctor's Hospital and where Dr. Davis works. She works at Family Medicine Center and Bahama Health and Healing as well. And we have a plethora of men and women walking through our doors with obesity, high numbers of obesity. We have 80% of our women who are either overweight and obese. And like I showed you here, we have over 50% of women who are obese. We must focus on the women in particular, because in the Bahamas, women are the drivers of our homes. Women, we have a lot of single parent women, and they work 2 and 3 jobs. So what are we going to do with this dilemma in this Bahamas? We need programs, we need community health programs, we need everyone working together to combat the expected rise of obesity among our adults in the Bahamas. This graph from 1988 to 2019 just shows you the progression of overweight and obesity in the Bahamas. And this one stopped at 2019, where over 40% of our Bahamians were living with obesity. Children, our darling children. Years ago, I did some work with Dr. Lightburn, the pediatrician, and he said, we're loving our children to death. And this was over 10 years ago. It is predicted that by 2035, the increase of obesity in children are going to be even at 100%. It has been rising since 2020 to 2020, from 2020 right straight through to 2035. It is estimated that this increase is going to continue. So we could see with children, we have in 2013, we had 23.7, 24% of our children who were overweight and obese, and 22%, 21.6 were obese. The girls, and if we notice that the girls are leading the pack, the women, the females, the adult females led the pack with obesity as it relates to male and female. And we can see that trend here with this graph as well. And this was in 2013. So let's talk about obesity. And that is what the World Obesity Day was about. And in the Bahamas, I feel that it's relevant. I feel that we need to keep this conversation going, because you know, the World Obesity Federation confirms that these numbers are going to continue to rise right into 2035 and beyond. So what is obesity? It is a chronic relapsing disease. And it is relapsing because we are obese because of the food we eat, the food choices, the foods we choose, and the amount, the time that we eat it. But more than that, it is relapsing because if we take the food away, then that's unethical. We need food to survive, right? So how do we address this obesity? It fits into the epidemiological model of a disease process, and that's why it's relapsing. That's why persons who are obese need and should work with someone like myself, a behavioral therapist, a disease management specialist, someone like Dr. David Simmons, who can help you identify the reasons why you eat the foods you continue to eat, despite knowing that you're going to get sick from it, and that if you continue to gain weight, it's going to place you at a greater risk for developing illnesses like type 1 diabetes, type 2 diabetes, high blood pressure, high cholesterol, and other conditions which Dr. David Simmons is going to come along and speak to you right now on how to move forward and how to address the issues that as a result of this epidemiological disease and that is diet related, but also causes problems throughout the body. Dr. David Simmons.
Okay. Is it working? Okay. All right, let's go. Let's hold it. Yeah, thank you.
So factors leading to obesity. So classically, we think it is just taking in too much calories and having a genetic predisposition, right? I come from big people, so I'm big boned, right? But it's really much more complex than that. Yes, it's eating high caloric foods, and you may have a genetic susceptibility, but it's much more than that. So stress can increase weight gain, emotional stress, physical stress, not sleeping well, having a sedentary job, not moving, so sitting down watching TV or scrolling your phone instead of walking or exercising. Women, as we age, when we go into menopausal transition, you can have an increased weight gain, you can have slowing of the metabolism. Women in general, post-baby, can't throw off that post-baby weight, so it kind of accumulates with each pregnancy. So it is multifactorial. Some of the medications our doctors may put us on can promote weight gain, right? So it's much more complex. So the body wants to hold on to that higher fat. This is why it's best not to get heavy. The body wants to hold on to it. So it's called the adipocyte set point. All right, so the body always tries to protect that highest fat mass. So when you start to lose weight, you have a lower mass and you have a lower, what we call resting energy expenditure. So your body needs less calories at a lower weight just to function. At a higher weight, it needs more calories, it's burning more calories. So as you lose weight, you have a reduction in the resting energy expenditure, and to continue losing weight, you have to maintain the exercise output and continue to have a smaller caloric input to keep that negative. It has to be a negative deficit to continue to lose weight. So the body has what we call these maladaptive mechanisms. So as you start a diet, I think everyone who started a diet knows when you kind of get past those couple days, you start to feel real hungry, right? Right? You start getting hungry and you kind of fall off the wagon. That is not because you don't have willpower. The body is putting out hormones that make you feel hungry. There's hunger hormones, hormones called ghrelin. There are satiety hormones that make you feel full. And in people who are overweight or obese, what we find is that sometimes they may have a resistance to those satiety hormones, those ones that feel full, make you feel full, or they're not responding to it as well. All right, when we think about obesity, there are a lot of comorbidities that are associated with it. So it's not just carrying a little extra weight on your midsection. The fat cells itself, the excess fat, acts as a endocrine gland. They produce hormones. And those hormones that excess fat creates results in these metabolic issues. It increases insulin resistance, increases inflammatory markers, increases the risk of heart disease, pulmonary disease, obstructive sleep apnea. In women, there is an association between PCOS and obesity, infertility. In men, you can have low testosterone because of obesity. So it has many effects on the body. You have increased risk of solid cancers in obese individuals, such as breast and uterine and prostate cancer. So how does obesity itself drive these diseases? One, from the sheer weight. So having the excess body weight can lead to mechanical issues where you have joint pains, knee arthritis, you can have sleep apnea, reflux, urinary incontinence, you can't hold your urine, and many other diseases. And then we talked about the excess fat having inflammation. It can increase the risk of clots, of prothrombotic, meaning increased risk of clot formation. The hormones it releases causes elevated in blood pressure, elevation of blood pressure, insulin resistance, and other problems. So we know if you are overweight or obese and you have some of these metabolic disturbances, just even losing a small amount of weight can have benefit. So if you have type 2 diabetes, losing at least 7.5% of your excess body weight can lead to improvements in blood sugar. If you have prediabetes, 7.5% weight loss can lead to normalization of your blood sugars. If you lose 20% or more, diabetes can go into remission. Sleep apnea resolves with weight loss. If you have sleep apnea, if you have fatty liver disease, losing 10% or more of your weight can lead to resolution of that. So when we talk about obesity management, so I already kind of set the stage that it's complicated. It's not one thing, right? So when we talk about obesity management, it's a layered approach. It's not just you need to start diet and exercise. So it is a layered approach. So diet obviously has to be a caloric restrictive diet. So you have to have a deficit. And just by reducing what you take in by 500 to 750 calories, you can lose up that problem. So it doesn't have to be a huge deficit. And then get it moving so that you continue to have that deficit and help to prevent weight regain, and then behavioral modification. So those are kind of the cornerstone of weight loss. And I know Dr. Martin's going to talk a little bit more about behavioral modification, but that pillar, that yellow pillar, is so important because how we eat, how much we eat, when we eat are all learned behaviors. And a lot of the times we learn those behaviors from our family, from childhood, and we continue that into adulthood. And that is one of the reasons, one of the components of why we have to put this away. So it's unlearning those bad behaviors. If someone is not reaching their weight goals, we can then add on other therapies. So that would be obesity medications, to assist them in weight loss that's added on to diet, physical activity, and behavioral modification. And for some individuals, you can consider bariatric surgery to help them reach their goals. So when we talk about obesity medications, like I said, it's an add-on. It's not used solo, and it can be used in individuals who have a BMI of 27 or more with one or more obesity comorbidities. So if you have diabetes and you have a BMI of 27, you can consider using weight loss medications to help get you to goal. Or if you have a BMI of 30 or more with no other obesity-related diseases, you can then consider using obesity medications. So I want to highlight, I did mention this, there are other medications that you may be on for other reasons, blood pressure medications, certain diabetes medications, mood, antipsychotics, antidepressants that can be leading to weight gain. And as you see, a lot of medications that we use, antihistamines, Benadryl. So if you're using that every day for allergies or using that to sleep, that can be promoting weight gain. So there's lots of medications. If you're struggling with weight and you have a physician, you should say, are any of these medications adding to my weight gain or making me difficult for me to lose weight? Because then they can switch it out for something else. So that's a conversation you should have also. So why do we talk about obesity medications? Why? Because obesity is a chronic disease. So as Dr. Martin said, it is relapsing and remitting. And do you remember when I talked about those hormones? Your body is actually trying to get back to that higher weight, right? So this becomes this constant battle. So this is why weight loss medications came along to help people maintain the weight if needed or reach the weight goals. And we know that the biochemistry and the physiology of people with obesity is different than that of weight people. It is not the same. It is not lack of willpower. And when obese people lose their weight, their biochemistry doesn't go to someone who's lean. Again, the body is still trying to get back to that higher set point. And adding these weight loss medications, they help to change that biochemistry. Most of the newer FDA-approved weight loss medications help to change that hormonal imbalance. Where we talked about the hunger and satiety hormones, these medications help to boost the satiety effect, so you feel full, so you're able to maintain the weight. And as I said, addition of medication should be added to a comprehensive weight loss program. It should not be the whole program itself. All right, so these are a list of the FDA-approved medications. The latter three are kind of the new kids on the block. And I would say semaglutide and tirzepatide are probably very much TikTok famous. So semaglutide is lower dose of Ozempic, which is diabetes, higher dose pure obesity medication is Wegovy, right? Same medicine, higher dose is pure obesity. And then tirzepatide, lower dose Mounjaro, and higher dose Zepbound. And these are weight loss medications. These are pure obesity medications at the higher dosing. So how do we go about choosing which medication would be right for an individual? So we look at, after we have your assessment, so you would meet with someone like Dr. Martin first, and we go through kind of your weight history, and we go through your comorbidities. So the medications we choose may depend on what other issues you may have. So for someone who has diabetes, those latter three that I showed on the screen, we would probably choose one of them because it will help with lowering the sugars, but also help with weight loss. So that would be like your Ozempic or your Mounjaro. We also think about patient factors. The newer medications are all injections. So if someone is afraid of needles, then you would think about an oral medication. You want to know, are they in terms of insurance, is insurance going to approve it? Are they paying out of cash? And then you talk about other factors and access to medication. So when we talk about obesity medications, and this is why it's added on to a comprehensive program, and it should not be the program itself, where it's all about the medication. Because this is a study that looked at semaglutide, which again is lower dose Ozempic, and then higher dose is Wegovy, is that if you see the first ladder, the yellow part, that's the lead-in time, and you see the weight change. So that's in the first 20 weeks, people lost, this is percentage of weight, up to 10% of their body weight. All right, so if we're talking about a 200-pound person, they lost 20 pounds by 20 weeks. However, when they switched them to the placebo, which is that gray arm, as you see, the weight came back, right? Because these medications only suppress appetite. Once you stop it, appetite comes back. But hopefully you would have that behavioral modification, that diet in place, that exercise program in place to maintain the weight loss. And these medications, when they look at all these studies, they're meant to be long-term. They're meant to be, you're on it indefinitely, okay? So as you see, for the ones who continued on the semaglutide or the Ozempic up to 68 weeks, they continue to lose weight, all right? So that's one thing to put in consideration. This chart is just showing the different medications that are available and the weight loss that we see with them. In green, the last part, I have a projector, a light, but the Ozempic, as you see, 17.4% weight loss at 1 year in certain individuals, depending on the study. And in the yellow bars are the placebo where people are just doing diet and exercise. So as you can see, these medications are robust and can lead to significant weight loss. This is just a timeline comparing different medications with the newer medication, Mounjaro or Zepbound in the red, can lead up to 20% weight loss, which is almost rivaling surgery. So the surgery component, which is sleeve gastrectomy, or we call Roux-en-Y bypass, people are losing about 30%. So the newer agents are almost rivaling that. All right, so when we talk about surgery, who is a candidate for surgery? Individuals who have a BMI of 35 or more with obesity-related complications, so diabetes, sleep apnea, or if you have a BMI of 40 or more without any obesity-related complications. So the first picture is showing the balloon, the gastric balloon. This is a non-metabolic surgery, meaning it does not change those hormones that we talked about, hunger hormones, satiety hormones, but it is inserted into the stomach via an endoscopy. So do an endoscopy, put a camera down, and then the balloon is inflated. So it takes up the most of the space in the stomach. So it makes you feel full, right? Depending on the balloon, it can be in there at anywhere from 6 months to 12 months, depending on the balloon. And this is meant to be, again, added on to lifestyle changes, right? So you're supposed to be following a diet plan, exercise, so that when the balloon is taken out, you can then maintain and have all of that behavioral modification. The other two surgeries are metabolic surgeries. So they change the hormones They make you feel full, obviously, because the stomach is smaller, but they also change the hormones. So the more common surgery is the sleeve gastrectomy. So if you think of the stomach, everyone's stomach is about a football shape. My stomach, someone who's 300 pounds, same size stomach, right? So when you do the sleeve gastrectomy, they're removing about 80% of the stomach. So it's only a sleeve that is remaining. That's why it's called a sleeve gastrectomy. So this is a restrictive procedure, meaning that you cannot eat over a certain amount incident. They also remove the part of the stomach, the fundus, that releases those hunger hormones, ghrelin, all of a sudden makes you feel hungry. So that's removed. So it also helps you to feel full, right? Again, with this
Okay, so we're back. Okay, all righty. So as Dr. Davis Simmons says, a lot of the pillars of obesity is behavior modification. How do we modify our behaviors? How do we modify the amount of foods we eat? The types and make changes with the types of foods we eat. We get a lot of feedback from patients who say that eating healthy is expensive. Lately, I've been doing a little research, and I'm looking at the cost of a meal from a restaurant or fast food restaurant compared to going into the grocery store and buying a chicken and buying some vegetables. And then if you have a family of 3 or 4, how long that meal that you prepare at home would take you. And in most cases, if you're eating the right portions, you can do seconds out of some of the meals. Whereas if you stop to one of the restaurants, that's a meal for that time of day. You very rarely have leftovers. And as Bahamians, do we really have leftovers after we have a meal that we love? Just asking. So how food and lifestyle choices affect our health? When we choose the healthier options like the fresh fruit and the fresh vegetables, we have a lot of farmers markets here in the Bahamas now, and we have a lot of persons beginning to do some backyard gardening. If we can just focus on the fruits and vegetables that are in season, then maybe it won't hurt our pockets as much. As I mentioned earlier, when I gave you the prevalence and the statistics, I also ended by saying a lot of this obesity that we're seeing are among low income persons. Persons living in communities that some parents are working 2-3 jobs to just get the rent and everything else paid. But there are options to fresh fruits and vegetables because you can go into the frozen and get frozen fruits and vegetables. A lot of the major grocery stores at the end of the produce aisle now, they have baskets of marked down fruits and vegetables from the week prior. Everyone's into smoothies now. Take them home. Have your kids be involved in preparing them and put them in the freezer. You can steam some of those. You could stir fry some of those, and you can make smoothies. And so, I'm here making the case for eating healthy. Does not have to be expensive, especially given the numbers and the diseases that come out of obesity. All right, whole fiber, whole grain foods. That's your fruits and vegetables. That's your whole grain breads. That's your quinoa for those who know what quinoa is. That's your brown rice. And brown rice to Bahamians is the white rice, peas and rice. That's brown rice to us. But that's okay if that's what you can afford. Then we're looking at portions. The portions of rice is a 1/3 cup. A 1/3 cup is less than the palm of your hand. So when we talk to persons about changing behaviors to this model that I have here, it can be done, but it's going to take time. Why? Because as Dr. Davis Simmons says, a lot of the eating patterns come out of culture. It starts from within the home, from childhood. Us telling our children, child, eat all of that food on your plate because you know how many people starving in the world. Or you know how much I pay for that and you don't know if you can get the next meal. And we have to be real, that is our culture. And our culture has us, and our behaviors and habits have us in the position we're in today, being 6 or even lower in the world now, because we're closely behind the United States, a much larger country. Monounsaturated fats, what's that? That's your good old extra virgin olive oil or any plant-based oil. If you're doing corned beef, we can make corned beef healthy. Just don't add any more oil in the pan because corned beef already comes with its oil. So there's ways to make the foods that you can afford a little healthier. Throw some cabbage, some onions, some sweet peppers, fish and beans are high in fiber. The beans are, and they help, fiber foods help to keep your blood sugars down, blood cholesterols down. It fills you up and keeps you full longer, which makes you, not desire food because you're full. But then, as Dr. David Simmons says, we have some habits, and that's the behavioral side as well. We have to become mindful and not just mindlessly pick and eat when we're feeling full after eating these types of foods. Regular physical activity. The American Heart Association, the American Diabetes Association, World Health Organization, and I can call them all, they recommend 5 days a week, 30 minutes each time. Now, if you want to lose weight, they recommend increasing that 30 minutes to 45 minutes and then an hour, sustaining an hour. They also recommend decreasing the caloric intake. So if you're taking in 2,500, in some cases, when I take on nutritional assessment, persons are eating all day, literally, they're passing someone's desk and asking for, you hungry, you have a cracker, I feel hungry. And a lot of times, if we just ate breakfast an hour or two ago, we cannot be hungry. It takes about 3 to 4 hours for everything to digest in our stomachs. And so when we choose, when we're continually snacking, we're affecting our blood sugars, and also excess weight gain happens, okay? So I sidetracked a little bit by saying that we're snacking and eating mindlessly. But if we focus on mindful eating and eating the right portions at the right times, then we will, not only will we get full and stay full longer, we'll reduce our weight, and we'll reduce the caloric intake. Some of us will reduce from maybe 2,500 calories in a day to 2,000, because it's recommended that we reduce our caloric intake by 500 to 700 each day. And for some of us, that would look like maybe from 2,500 to 200. And if you're up to 1,800, then you go down to 1,500 calories if you want to lose weight. These are the excellent benefits of including more fiber, more fruits and vegetables, and fish and beans in our diets. We have not only weight loss, but a decrease in our blood pressure, blood sugar, and blood cholesterol levels, and triglyceride profile. And it lowers the risk of us being diagnosed with a chronic non-communicable illness. My slides not moving. Okay, so we have our drum, and I've pretty much gone through this, so I won't spend a lot of time on this. I use this acronym for persons. If we consider planning our meals, plan your grocery shopping list, write a list before you leave the home. So planning is the key to success in weight loss, in those behavioral changes that we need to make. When we plan, then we don't overspend in the grocery store, because we're walking in the grocery store with a list of things that we need, because we looked through our cupboards and refrigerator. And then when we plan, we're also looking at ingredients. We're looking at the low glycemic index carbohydrates. We're looking at the high fiber foods, more fruits, more vegetables. Preparation, how are we preparing the foods? Bake, boil, broil, or grilled with very little or no sauce. And portions of the food on your plate. We want half the plate to be vegetables, and then you can throw some fruits there for kids and for adults if you want the whole half just vegetables. A quarter of the plate, whole grains, or your rice if you want. Which we're coming up to Easter now, and everybody, what did we get? Hot cross bun. Well, a bun is one small bun. A bread is one slice of bread. So it fits into that quarter portion. And then the next quarter is your protein, which is about 4 to 6 ounces of whatever protein it is. All right. So that's what this slide gives us. And so these are the things, these are your improvements in your overall quality of life. When you do focus on healthier options, you not only maintain your weight, but it reduces the risk of you becoming overweight and obese. Also, when we choose half our plates with vegetables and add fruits to our plates, we're getting in the supplements that we're purchasing over the counter. We're getting in vitamins. We're getting in minerals. Supplements are just that. It supplements what we're not taking into our food on a daily basis. It boosts our immune health. We're not getting sick as often. All those little bugs that we see around, we're not really exposed to because our immune health is up. It improves our digestion and it reduces, as I said earlier, the risk of chronic diseases. And it reduces our risk of some cancers as well. So if we eat, energy in equals energy out. And so if we eat, we need to move our bodies. In the Bahamas, I think in the last survey they did, they showed that not many people were moving, not Bahamian people, a lot of Bahamian people were moving. But I think that has changed now. As I move about, I see more Bahamians out on the road. I see families with their children moving them around the parks, which is important because we have an increase in childhood obesity. Yet, children should be moving an hour or more every single day. And so we aim for 150 minutes a week. That's that 30 minutes. And if we want to lose weight, we increase it by 200 to 300 minutes, 5 days a week. That's like 45 minutes to an hour, 5 days a week if we're looking for weight loss. And these are just some groups of fitness that we do. Aerobic, that's running, walking, swimming, cycling, and then resistance training, and then relaxation. So the benefits, we burn calories, we reduce our blood pressure. So you see the trend. Once we eat healthy and we bring in that exercise, we're coming with a 2 pound with that weight loss. But not only that, we're also increasing our moods. We're sleeping better and we're feeling better about ourselves. We build bone density as well. We increase our bone density. So when we talk about behavior modification, I cannot stress, I cannot stress the point of not managing the stressors in our life. We all have stresses in our life. Just the mere fact of being alive and having a job or having family or friends, that comes with an element of stress. And we have good stress, we have bad stress, we have happy stress, we have unhappy stress. We eat when we're happy, we eat when we're not happy. And so that's where the behavioral portion comes in, not only with the food and the fitness. We have to address the stresses in our life. And we address them. For me, I sit and ask person sometimes after the nutritional assessment. I put my pen down and I say, okay, so what's really going on? Because some people come and say, well, I don't eat, I don't understand why I'm gaining the weight. And when you do the nutritional assessment, they're really not taking in a lot. Some of them are drinking their calories, because we can do that as well through all the juices and sodas we drink. But a lot of times we're not, some persons are not mindlessly eating. There's some other things happening in their life. They may hold all their calories until the end of the day and eat in secret. Right? Because there's so many people being stigmatized and discriminated, not only on the jobs now, but in when I did my dissertation and I worked with some obese ladies, 1 or 2 of them said when they would walk into stores, immediately the sales clerk would say to them, we don't have your size in here. They could have been shopping for a niece or a family member. That's the discrimination and the stigmas that obese people, especially morbidly obese people, face on a daily basis. I'm working with some families with children. Some families with children are being stigmatized in school and bullied for their weights. They're not moving with as much agility as their peers. And so, I say to them, when we start to change behaviors, we need to practice awareness and the triggers that cause us to mindlessly eat or to not want to go out on the park and exercise. I work with patients who don't even want to exercise in public. And so, the YouTube has a lot of different exercises that I point them to. And so increase awareness around triggers, and those triggers are discrimination, or it could be, it's a family function and they have everything I love and I can eat everything that's there. So whatever trigger it is, identifying your feelings. Someone might have said something to you and that triggered you eating in secret, or that triggered you overeating at the end of the day. I've had patients who said to me they avoid certain streets on the way home because when they're passing the particular restaurant that they tend to go to because they know what they're going home to, they avoid those streets so that they're not triggered to go in to the drive-through and eat a meal before they go home to have another meal with their family. So there's a lot of stuff people have to unpack as it relates to stressors and daily encounters. I encourage persons to increase the planning. Remember the PIP, planning, ingredients, portion, increase your planning, set some boundaries, create structure in your life. Even if that structure is at 7:30, 8 o'clock, I'm turning off my phone. And if it's the work phone, I'm not looking at it until 9 o'clock the next morning, God's willing. You have to set boundaries around yourself and pull in some support systems. And if you notice with stress, support systems is at the end as well. Those support systems are going to encourage you, motivate you when you lose your first 5 pounds. As Dr. David Simmons shows you, 5% of your weight loss can reduce your blood sugar, blood pressure, decrease your risk of cardiovascular illnesses. And setting realistic goals. If you have been overweight for a very long time, don't expect to start a program and lose all of that weight in 1 month. And then when you don't, you're discouraged and you say, I'm not going back to that person because they didn't help me. The help has to begin with you, beginning the awareness, beginning to implement some mindfulness and some realistic goals, setting those, and then you taking responsibility first, and then your support systems come along. And so the way to get started is to quit talking today, to quit saying to your friend, child, I got this weight on and summer coming and I want this summer body so I can start. Start today. So quit talking and start today to take your weight in hand. Speak to someone who can assist you with making realistic goals so that you increase your overall health and wellness. Thank you so much for having us.
All right, so at this time, we would like to open the floor to any questions. So, okay. Natasha, go for it.
I'm a nurse by profession, so I understand the makeup of the job. Now, the biggest thing I realized when I was talking to someone on it, like a friend who's on it in the US, she's like, her biggest issue with it was the cost. I don't know what the cost factor is for persons who want to do that for care. Is it as expensive as it is in the US or?
Right, yeah, no, it's expensive. So, no, it's expensive. So remember, Ozempic is the diabetes dose, right? That's the lower dose. If you're insured, insurance will cover it. If you're in diabetes and you're overweight, because that's what it's made for, right? With type 2 diabetes, so insurance will cover it, the patient has 20%. If you are using Ozempic off-label for weight loss and you got to pay for that on it, it would be depends on the dose you're on, anywhere between 600 to about 1,100 a month. And you gotta remember I showed you that slide. When you come off of it, what happens? Right? So it's so when patients do it and they don't have a plan in place, a weight loss plan, if they don't have behavioral modification, it's throwing your money away, right? So yeah, it's expensive. And then the Wegovy, which is the higher dose that is marked, that is Ozempic higher dose, same med, that is pure obesity, is probably double the price.
Yeah, but someone said it's 500.
Yes, the hot, no, so the thing is, people are compounding it, okay? So Wegovy ain't $500. That ain't $500. It may be they're compounding it kind of off label and using it in a vial and syringe. It does not come in a vial and syringe. It comes in a pen that looks like an insulin pen. So sometimes that's how they get it cheaper. Pharmacies are compounding it.
I just want to add here as a footnote, you can have those behavioral components with nutrition and fitness.
Oh, it's
included.
not.
Yeah, no. I think generally though, because we've worked with persons who lost the weight on the medication, they've come off now and they're gaining the weight back. And so what we're addressing with them is some other issues that cause them to overeat. So it's not so much that they don't understand the nutrition and the fitness component, like that ended with the mindfulness and addressing those underlying issues. Your relationship with food is also important. And unless you're Oprah, who can afford to pay for you know what I mean? That
It's become a celebrity drug, because they're the ones who can afford it.
Yeah.
And we want to live.
Yeah,
exactly. That's it's easy.
but it's meant to be, when they market these drugs, it's meant to be like that.
And then, you had mentioned some of the medications that put on weight.
Yes.
I know as a nurse, when you give persons, like particularly persons, like a lot of younger women come in, and because everybody tells them go on the shot, a lot of them ask to go on the
Very
shot.
depot, yep.
And, at least in my case, when I went on it, I was in my late 20s. I went from like, BMI 24 to like, I think they put on like 60 pounds within
Yep.
6 months. And it was like ridiculous the amount of weight that just put on, like just from now one drug. And when you learn about it, it's like, you know what? Before you go on a drug, you should find out what the actual side effects are, so you can decide, hey, does this outweigh the benefit?
You're exactly right. I mean, there's so many common medications that have increasingly been.
So I have a question that relates to benefits of fasting. Sure, there are numerous benefits. There's a doctor, and the following is, as a matter of fact, Dr. Jason Kwan. You can look him up on YouTube. He has numerous YouTube videos. You reduce your blood sugars if you're diabetic, and even if you're not diabetic, it's a good insulin glucose ratio during the fasting period, right? And also, after you fasted for so many hours, say you go beyond the 16, 18-hour fast, right? On a regular basis, your body goes into autophagy. That's a stage where you start to build new tissue and repair and burn the excess fat, which is stored. Of course, there's excess fat stored in the livers, yeah? But you live off of those excess fats and you reduce your blood sugar levels, and the insulin blood sugar ratio is normalized. It also helps with lowering blood pressure, blood sugars. And as a matter of fact, when you get to a certain point in fasting, your energy levels are increased and you don't feel the hunger pangs. All right. So what I do when I work with patients with intermittent fasting is we start with spacing meals 4 to 5 hours. And then after a couple of weeks, then we go 6 to 8 hours. So that means you miss a meal. But in that, a lot of persons are intermittent fasting, and during their fasting stage, they're drinking coffee with cream and sugar. That's not fasting. You see, they're drinking a smoothie. That's not fasting. Fasting is plain water or black tea, black coffee. Those are some. Jason Fung, he has a lot of YouTube videos.
Just one comment. When we talk about intermittent fasting, right, it's time eating, but when you break that fast, it still needs to have a calorie deficit
That's right.
if you want to lose weight. Okay, I have a lot of patients come to me and they said, oh, I'm intermittent fasting, and you hear what they're eating when they break their fast. They're getting 3,000 calories, and wondering why they're not losing weight. That still needs to be coupled with a low calorie intake to have that deficit.
And the right carbs, the low glycemic index carbs. Yeah, so in that eating window, as Dr. Simmons says, time eating window, you have to be careful with choices.
So it sounds that I'm intermittent fasting.
Yeah.
What are you really asking?
Yeah.
Okay.
I like the idea of restoration of body tissue.
Yes.
Oh, yes.
Yeah, so the circadian rhythms, internally disrupted, and healing takes place that we can't even see.
But think about it, right? So when you're fasting, right, the body is not diverting blood to the stomach to digest, so your body can focus on other things, right? So it kind of does make sense.
You have a list, right?
I have, two questions,
Mhm.
they're both Ozempic related.
Okay.
So one says, what is the side effect of Ozempic?
Okay,
We'll stop.
what's the other one? Because I may be able to answer
The
that.
other one says there's an uptick in the number of Medispas offering Ozempic. How do the doctors feel about this?
Okay, good. Okay, so what are the side effects of Ozempic? So the side effects are gonna really be related to how the medication works. Okay, so the medication is a GLP-1 agonist. I don't know if you remember the slide. GLP-1 is one of the hormones that are made from your intestines. We all make GLP-1, okay? So when we eat and food goes into our stomach and it stretches, your body produces GLP-1. That sends a signal to your brain to say, hey, I'm full, stop eating. Right? So what these medications are, they are GLP-1, right? So they are causing this huge GLP-1 surge that makes you feel full. It also, GLP-1 also has a role in slowing down the way the food moves through the system, right? Slows the transition of food. So that also makes you feel full. So when we talk about side effects, it's related to that. Meaning some people are, nausea is the most common side effect. You can feel nauseous initially when you first start, because that's because of how it works. Your body usually gets used to that as it gets used to the medication. So when we start these meds, we start slow and we do increase every kind of month or so. So your body gets used to the medication. Some people get more constipation, again, from that slow transition. So I would say constipation, nausea, stomach upset are the most common symptoms. And that's related to how the medication works. And those symptoms usually resolve. How do I feel about Medispas using it? I feel mixed reviews, mixed things, because remember what I told you, people are using it, when they use it at the Medispa, it's not coupled with a diet program, exercise program, or behavior modification. So it's just creating a quick fix, right? So, okay, I got something to go to, I want to drop 20 pounds, fine, it will work for that, but as soon as you stop it, the weight is same. So I'm a big believer in weight loss medications, but it needs to be added on to a program so that you can have some future success. If you decide to come off of it, you want to be able to maintain the weight. The whole yo-yoing in weight kind of just damages your metabolic rate, right? So for my patients, I want long-term success, not a quick fix. So hopefully that answers the question.
I do have a question.
Yeah.
So when we were talking about the bariatric procedures,
Uh-huh.
specifically the gastrectomy and the bypass,
Yeah.
are they at any point reversible?
No.
No.
No,
Okay.
no. I mean, so the patients who we are considering, now, so the bypass, we're not really doing as much, okay?
Mhm.
The gastrectomy is now really what the standard of care, there's less side effects with that. So the patients we are choosing for these type of procedures are people who have struggled their whole life with weight loss. So we
Okay.
do want a permanent solution for them. So it's not a reversible procedure.
Okay. Your turn.
Just our statistic basis, right? And it varies for sure. Two questions related to that. One, it's been a few years since that was taken. How does that census come back? When will they be taking those?
I don't know, that came from the World Health Organization in 2014. Now, the World Obesity Day and the World Federation. Yeah, 2014. So the newest statistics is what I gave you, to 2019. Yeah, those slides, if you go back. to the
Yeah.
slides. Yeah, those are the latest, stats that we have, 2019. And so, but you can see the increase.
And you know, when we do a part of those conversations where we talk about, you know, data where it comes, right? So probably don't have the best data, but that's still a lot.
It's a lot.
Related.
That's this one here?
And
That's this one here? Is this one? Okay.
It's not showing up on there.
Yeah, I know. I turned it off because it's on.
And so we talk about BMI, right? That throw me off. I really appreciate you speaking to independents like weight bodybuilders, which I'm not, you know, or, you know, but that throws me off a lot, BMI does. And I feel that, I don't know, for those of you who, have been very blessed in terms of being healthy, right? I don't have anything as of yet, right? But, my BMI says always, right? Work out, eat healthy. My body's changing, I think, because I'm maturing. But it changes, right? Like, who is this? This is a me. But it's funny, doing all the things you're saying. So it's honestly time that I need to visit one of the two of you, right? I'm saying all that to say that I think it's such an individual thing, because I also feel, you're gonna laugh, like, the bigger I get, the more compliments I get from men in this society. Like,
They call them Gussie Mays.
They call it what?
Gussie Mays.
Oh,
Solid.
like someone else. So, you know what? I feel good. The men are checking me out. You know, good. Whereas it could be, and there's could be someone that's like, hopefully, you don't get to go check it out because you feel fine and I'm really good. You know, some of that out there for PSA.
Yeah.
Okay, the other thing is, the long term, you know, it was interesting to me to hear that. I think it was in your presentation related to some of these long-term therapeutic medications that don't like, you know, and my point is going back to trying to prevent it. You know, what's your therapy care? We're talking about the youth. You know, as you know, we've partnered with Ridgeland Primary, but starting there with children and parents. And I love also that you touched on, I'd like to speak a little bit more about, because I think you would certainly get a lot of debate about, is it cheaper to go? Because it's, you know, I mean, you know, I'm in a dual income household, and I have to decide I'm gonna get strawberries this week. You know what I mean? It's pricey. You know, it's priced in balancing that out. How do you, like, what's your message to those that really do have that argument? I've heard you talk about looking at, you know, eating for one meal or buying for a few days. You know, you've done that work and it does truly balance out. I think it's important for us to hear that message again.
No, I've done the work, and I'm doing it now with the change in cost. I just stopped into one of the fast food places that did a screenshot of their cost, so that I could compare it with the cost in the grocery store and create, you know, meal. Where if you create that meal, you know, do use that, okay, plan your meals, get the ingredients, go home to prepare them. You also have extra of the ingredients left in the refrigerator and the cupboard. Whereas when you go to one of the restaurants, that's just one meal. And you spend up to $30 if you have 2 to 3 children and yourself, sometimes more, for that one meal, right? And so I think it's a mindset change. I know it's a mindset change, and it's based on culture. When I sit with parents, and when I sit with adults who say to me, it's expensive to eat healthy, and then I outline it, they say, you know what, I never thought about it that way. Why? Because we're living mindlessly. We're making choices and decisions without really thinking our way through. You know, and if we think our way through, we're going to save money at the end of the day, not at the ticket counter, not only at the grocery store counter, but in health conditions. I had a 5-year-old. We at Centerville Medical. That 5-year-old is pre-diabetic. That 5-year-old is over 100 pounds. The mother get brought in, and the mother is overweight. And the mother is laughing, and she's saying that the child is solid. So that's the mindset, that's the culture. And I'm saying to the mother, but see, this is a healthy blood sugar. This is a not healthy one. And he's a 5-year-old. He's going to grow up with this condition into adulthood. If he reached there, and then he will have some other chronic diseases attached to it, mechanical diseases like conditions like what Dr. David Simmons mentioned. So I hope I spoke to it.
You did,
But I
I'm
do-
curious, but I wanted to post.
Yeah,
So,
yeah.
and it really is a mindset that
Yeah.
we're changing. For sake of time, I'll talk to the faculty.
But there's another question that came through that's also pediatrically related, so I'm happy that we shifted there. A question is asking, how do I get my toddler who's on the spectrum to consume fruit and vegetables? He only eats banana and no vegetables at all.
What you can do is mix it in other foods like a drink, a smoothie. Mix it with something else. Mix it with the mashed potato. When I boil potatoes, sometimes I will put in at the end, I will put in some broccoli pieces and let that boil and then smash it all down. And for us, a serving is only half a cup, although children need at least 6 to 7 servings of fruits and vegetables. But you can camouflage and introduce it.
Make great size.
Yeah.
Yeah.
Make it fun. Make it fun. Make it
Yeah.
fun for them. Yeah.
You have a question?
Just a quick question on that, I don't want to talk about, so I guarantee the vegetables, but my concern is sometimes the broth, that's the new broth, since we're on that. I'm concerned, is the nutrition still there, like, because I sometimes really knock it down. When I do like eggs and stuff, so I'm like, cooking this much, like to get it. Soft, is that taking away the nutritional value? Because like, before it's like, one had explode, so the nutrient.
Yeah. Yes, you are taking just a little bit, but that's better than none at all. Okay, and with the children, you're giving them multivitamin supplements anyway, hopefully. But we do need the conversation with children and what we're feeding our children, because we're feeding our children the same portion sizes as we're feeding ourselves as adults.
So the children, relatively eaters, the schools on the certain foods, and they keep touching, I don't do this, I don't do that. Like, but I have an auntie that only eats tuna. And I don't care what kind of vegetables and foods, like, everything, I don't want that.
Yeah. Children mimic what we say. So what do we do? And so if we encourage, when they start with, I don't eat that, say to them, why don't you like this? Or why don't you eat this? Where did that come from? It had to come from somewhere in the environment of that child. In addition to that, if you take that child with you to the grocery store and let that child pick, maybe, this week, let's try and let's do something new. Before you do that, every child has a laptop or some device that they're working with. Show them the vegetables and fruits on the device and ask them to pick one to add to the cart this week or next week. Get them involved in the preparation of the foods at home. And that will also spark their interest. But children mimic what they hear or see in an adult.
No, something, a suggestion I had, and this is something I learned with my own son. He didn't want, I can't remember what it was, but he never wanted to eat it. And one day we were out and a friend's son was eating it and he was like, try it, you might like it. So I realized sometimes kids, you may not be able to get it.
Yeah.
Other kids, and then even like the little role models, like the little kids, they watch on these YouTubes and stuff. Sometimes you find an episode where the kid is trying something similar to what you want them to try. And they will actually go into it because they want to do what they see their friends do. So they may not do it at home because they think it's adults, whatever, but their friend or another little kid or something else would do it. And then, like she said earlier, mask that. I mask a lot of fruits and vegetables at home with my kids. My son loves salads, my daughter not so much. So for her, particularly a lot of stuff, like a lot of the veggies have hidden in the foods. If I'm making a meatloaf, we make a turkey, garden one, so it have all the little veggies already mixed in a cheese. And thinking, oh, this is a good meatloaf for me. Yeah, it's a good meatloaf. It has all of the nutrients I need to get.
Very good. But I have to say, and I'm guilty of, right? How many of us, some of us, didn't grow up with choices, right?
Yeah,
Yeah. Right, it's much. I'm listening to you and this 5-year-old who's obese. That 5-year-old can't cook, can't shop. Someone keeps doing it. Right, so start calling. And last thing I'll say, guilty of, we're also, in a society now, I'm also guilty of it. We want things, we want them now and quick. So it's easier to drive through than to go home and prepare and that type of thing. So the time we take, we're killing ourselves. We're being lazy.
Yes, that's right.
I mean, truly lazy. I mean, my stove went out once, and my microwave went out. My husband's like, the microwave went out. You went to the store in an hour and replaced that. The stove, it took me a while. But I think the microwave is
Yes.
it's just our mindset.
Yeah.
Very much so. She said, that is good. Oh, I'm confused. Oh, I don't cook it, but I don't cook, but I don't cook in it, but just the warmth.
The heat up, yeah, before that. Mhm. All right, no other questions? Okay.
This was incredibly informative and educational. Yeah, for sure. We could be here all day and, this, I think, for each of us independently, I think we had, thank you very much. We had some nuggets to take home, right? For those of us who have children, those of us that are single, those of us that are busy, our lives are busy and realizing that, hey, we need to slow down. And I'm okay then if I walk around skinny and nobody would see me. But more importantly, we're talking about our health, right? We're talking about our health, longevity, and what's important for us now and for our children in the future. And we want to say thank you, ladies, so very much for small. Oh, okay, I'll keep it in the middle, okay. Maybe let's look at small.
All right, so on behalf of the National Health Insurance Authority, we want to thank you for logging on to our session today. Please follow us on social media so that you can be informed about our upcoming wellness initiatives. And we wish you all a great day. We'll also be posting the video on our social media pages, so you can go back, like, watch, and share. Have a great day, everyone, and we'll see you next month.